Welcome everyone to today's webinar. I'm Heather Punke, Managing Editor with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will send you a copy of the presentation to the email you used to register. At this time, it is my pleasure to start today's webinar by introducing our presenters. First, we have Brandon Edwards. As founder and CEO of ReviveHealth, Brandon brings more than 2 decades of experience in healthcare and a track record that includes nearly 600 successful strategic communication engagements, C-level crisis and communications council, and other high-stakes issues facing health system leadership, profitability, and clinical excellence. Brandon earned his MBA from UCLA's Anderson School and is a featured speaker for PR and marketing trade groups, as well as healthcare industry organizations like SHSMD, AHA, ACHE, Healthcare Roundtable, the Governance Institute, and others. He was included in PR Week's Global Power Book in 2015 and 2016, which is reserved for the most influential PR professionals around the world. And we have Dan Prince, who is the founder and president of Nashville-based Catalyst Healthcare Research. He applies 3 decades of marketing and research experience to help healthcare providers, health plans, and suppliers achieve confident change. His firm offers both custom research and ongoing patient feedback programs to clients throughout the U.S. Skilled in both qualitative and quantitative research, Dan is also an accomplished moderator and presenter. He holds a BS in Industrial Engineering from the University of North Dakota and an MBA from Vanderbilt. Brandon, I'll now turn the floor over to you.
Great. Well, thank you and welcome everyone. We're going to provide a really quick overview here of what you're going to find in the following survey results. And Dan's going to give you a detailed look at how we conducted this year's surveys. But there's a few pieces of information I think that'll be important to keep in the back of your mind. We've been conducting a trust survey with a hospital audience, the only one of its kind for a decade, with a physician audience for the last 3 years. And then this is the first year we've added a new audience, which is actually interviewing executives from health plans who are charged with network development and network administration. So those people who really have a significant and primary interface with the provider world. And we have found really for the first time identified the trust gap that exists in healthcare in the B2B world and what's affecting that. So there's a few things that you're going to find as we walk through this, as you can see on the screen now. There are going to be some unpleasantly low levels of trust that we've identified between different sectors. Some interesting and very important findings on the transition from volume to value and the speed of that transition. And then ultimately what we view, and I think what all of us would view as a critical element of any B2B relationship, is trust. So we've all seen the research that's out there that measures these sort of dismal levels of trust that consumers have in the healthcare system. I think one of the things that we're really finding is that this research reveals that consumer trust in the healthcare system is low because B2B trust in the healthcare system is low, that if the core central parties in the healthcare system don't trust one another, it's going to be very difficult for consumers to trust that same system. So the good news is we're going to identify at the end of this presentation some things that can be done about that by all the different organizations. But this is really sort of first of its kind research that looks at the triad of the hospital health system world, the physician and provider world, and the health plan world. And with that, Dan's going to start to walk us through really the important details of the survey findings.
So for 10 years, ReviveHealth has been hearing from hospital and health system executives in this annual survey process. And again, that process was repeated this year. And we had 143 executives, primarily those who are responsible for provider relationships and for networking and network operations within their health system. So they're the right kind of people to be taking a look at health plans and gauging their level of trust in the respective health plans that we asked them to rate. And the survey this year was done totally online, and we had a decent sample size, as you see indicated there, of 143 participating health system executives. For the second year in a row, we've gone out to a broad base of practicing physicians across the United States. And in fact, we had 45 states represented among our 600 participating physicians in a separate physician survey, where we essentially asked them a similar set of questions to rate the major health plans, to help us understand why they feel the way they do about the health plans, et cetera. And as we did in the previous year with the physician group, about 75% of the total sample were specialists. The other 25% were primary care docs. For the first time this year, we have another perspective to bring to the table because, of course, all three of these stakeholders are involved in what's going on today in healthcare, and especially as we think about the transition from moving from a fee-for-service, volume-based payment arrangement to the new world of value-based. And here we heard from a total of 74 people who rated the provider types that we presented in this survey. We didn't ask them to rate individual organizations or brands, that is, a health system brand, but we did ask them to rate different types of providers. For example, is a large for-profit health system seen as different in terms of trustworthiness from a small nonprofit health system? And I'll get to that detail in a little bit. Now, you might say 74, well, it doesn't sound like a lot of people. And true, the margin of error on this is somewhat larger than the other two samples. However, the universe, of course, is much smaller, too, when we're talking about reaching people who are after major health plans across the country. And, by the way, more than one person from a given brand, health plan brand, could participate in our survey. So those are the three perspectives that we bring to the table this year. What did we ask them about? Well, as in the past, we have asked them about three components of trust. And these three components or attributes were derived from a research piece of work that we did on the academic literature to see what people define actually as the components of trust. And they are these, as you see them represented here. And the important point I want to make on this page is that we weighted them equally in order to deliver a composite score. So we're going to see what those composite scores are. But basically, they can run anywhere from 0 to 100, and I'll show you that scale in a moment. But just so you know, here's how we, in our survey process, define each of those attributes of trust. It has to do with whether the organization is actually honoring its commitments, and whether it's being accurate and honest in its representations, and finally, whether or not it's able to balance the interests of its own parties with those of outside stakeholders. And as we've seen in years past, in the eyes of health system executives, the one that payer organizations, that is, health plans, do the best on tends to be reliability. The one they're weakest on is that last one, fairness. So in terms of the scale that was used to measure the trust index, we used essentially this 5-point scale. And we converted their verbal answers of do you agree or disagree that health plan A represents itself fairly with its stakeholders and with health system executives. And they could choose any one of those 5 answers, ranging along from strongly disagree to strongly agree, and then we converted those into numbers, as you see here, so that essentially, a 50 is not a particularly good score. So, Brandon, what does that bring us to?
So I think as we start to jump into the individual scoring on these categories, I think there's a couple key things to keep in mind. One is that it's pretty clear from the trust ratings that the B2B relationships between health plan, health system, and physician are really sort of a triad of a shotgun marriage, really forced together but not there by choice. And I think that we can all agree, particularly in the transition to value, that that is not a healthy thing for the industry, that those are things that have to be improved over time and have been improved, interestingly, in some other very complex, highly regulated industry sectors. So it's certainly far from hopeless. I think the other thing that's sort of interesting to point out is that while we're going to present the scores, the composite scores, it was interesting that in all 3 industry segment surveys, the scores declined with each category. So going from reliability to honesty to fairness, in all 3 audiences, scores declined, which sort of leads me to believe qualitatively that we're dealing with an issue that's almost a passive negative, meaning the more we talk about it, the worse it gets, and the more frustrated people become when they talk about it. If we were to ask 4 questions, I think the 4th would have been worse than the 3rd, and if we asked 10 questions, I think the 10th would have been worse than the 9th. So the scores seem to decline the more we talk about it, which indicates there may also be some sort of pent-up feelings here, as you'll see as we start to reveal these individual results. So Dan's going to take us now through the scores by sector.
So how did health systems rate their level of overall trust in health plans? And again, here we're talking about the 6 major health plans in the aggregate. Those would be Aetna, Anthem, the independent Blue Cross plan that is the most important plan to a particular system in its state. It would include Cigna, it would include Humana, and United. So what we see in terms of composite score, that is when we equally weight the 3 individual components together, the composite score is just slightly above the 50 mark at 54. So it essentially tells us as an outside research partner that health system execs really are not in agreement that these health plans do these things and do them consistently and do them well in the eyes of these execs. And look at the physician number. It's, essentially the same. It's within the statistical margin of error here of 2 points. They looked at health plans and asked them the same battery of questions, and we see that their score comes out right in the same target range as the view of health system execs. By contrast, we found something very interesting here, and that's that when health plans look in the other direction, back towards provider organizations and types of providers, they tend to rate their level of trust in those different types of provider organizations at a higher level. And, in this case, 12 basis points matters. And so the composite score for health plans actually came out in the 57-68 range. So
I would point I'm sorry, Dan, just really quickly, I would point out one thing on that previous slide. It said health plans ratings of health systems. It is indeed health plans level of trust in health systems and physicians, just to clarify, and we will delve into that as we get into the subsequent research results.
Well, in fact, Brandon, that's a good moment for me to mention the types of provider organizations that we asked the health plan execs to rate. There were 7 of them. They included academic medical centers as one type, Children's Hospital is another, for-profit hospital groups, large not-for-profit hospital groups, small not-for-profit hospital groups, large physician groups, and small physician groups. So they were rating their level of trust in that type of provider organization when they're answering this battery of questions for us. So I wanted to share with you something about the variability of people's responses. Here we see that when we look at the answers that came in from the health system sector, there was really a big amount of variation between how they rated one of the major health plans versus the others in that same group, with one of the health plans coming out at the high end there at a 63, which of course is still not a great score, but it is certainly substantially better than a health plan that was rated at the 40 level. And so it suggests to us that health system executives have very different experiences with the individual major health insurance brands, and that's reflected here when we see such a wide range from 40 to 63. How was it with the physician group? Let's take a look at that.
When I think, too, just a quick comment on the last slide, and forgive me, we'll just pop back really quick.
Oh, yeah, let's back up to that.
I want to make two quick comments here. One is it's important to note that these are the aggregate scores, right? The 40.3 and the 63.3 represent the overall composite scores for the worst ranked health plan, the overall composite scores for the best ranked health plan, and all others fall in between. What that does not represent is the worst score on any one question, which in order to get to a 40.3 average, one would have to acknowledge statistically that there are individual scores, particularly for honesty and fairness, that actually dip below 40 for that worst ranked health plan. And so there's some of you may be asking yourselves, in past years we have actually released a scorecard of the ratings of individual health plans. This is the first year that we're not going to do that on this webinar or in the media for a couple reasons. One, we really wanted to identify the trust gap, and we felt that the only way to do that was to remove the individual scores of individual health plans that that may lead people to be defensive or deny that there are issues that are here. It's no secret who has been good performers or not great performers in the past. And some of those trends continue, although I'll take you in a moment through the notes at the bottom there that are really important. The second is that because we couldn't in any way with any consistency rate individual provider brands, either health system brands or physician brands, since there really aren't national provider organizations in the way that there are national health plan organizations. We just didn't feel that it was fair. So if we're asking people to rate these individual plans to reach aggregate scores, that's what we're releasing this year. We will make the individual scores available to individual health plans who would like to have that information, provided that it is not released to the media, as well as to provider organizations who are interested in that, which we'll do privately. But we just didn't feel that it was appropriate for what we're trying to accomplish here. The two notes at the bottom are really important, and so we're going to talk about movement here as opposed to individual scores. It is really important to note for Aetna, this is the single largest improvement. An already pretty well-rated health plan on the spectrum had the single largest movement up of any plan we've ever tested in any one year. A very significant movement overall, which is dramatic and worth noting. The other is that Blue Cross Blue Shield plan, so this is an aggregate score for the 37 independent Blues nationally. So it does not represent, to be clear, any one individual nonprofit Blue, but rather the aggregation of those scores, also had the biggest movement down by any one score that we've ever had in the 10 years of scoring these plans. And I think we're seeing a couple trends or so. To be fair, Blue Cross Blue Shield plans generally have been pretty well rated in the past, but there was significant movement this year. But it is also, again, fair to note that Aetna was pretty well rated and also took pretty big jumps up, biggest jump we've ever seen. So just with those as backdrop, like I say, we're not going to release individual scores, but as we go through this, those are important things to note, and I think we'll tie in particularly when we start looking at prescriptions for closing that trust gap in the future.
Yeah, sorry, I got a little ahead of you there, Brandon, because those are important points to make,
okay,
particularly for the people that are on the line with us today. When we do look at the second set of scores and the range there, we see something very different from what we just reviewed. Namely here that in the eyes of doctors, when they look at the health plans and rate them, they see very little difference between one brand and another, between an Anthem and a Cigna, or between an Aetna and a United. And you can see here it was only 5 basis points separating the best of the health plan brands in their eyes on this trust index versus the one that they consider to be the worst. And they all aggregate right around that same mark, hence the aggregate score of 55. So very little variability is really the point we wanted to make here. It's almost as if, to me, Brandon, they look at these health plans and they say they're all bad. They're all tough to deal with. I'm not really seeing much difference in the way I have to interact with brand A versus brand B versus brand C. Would that be your assessment as well?
Yeah, I mean, you'd love to see, I think, if you're measuring a trust gap, you'd love to see these scores in the 80s and 90s and still tightly grouped, right, where they say all the health plans are great and I have trust in them. And unfortunately, they're tightly grouped, but they're tightly grouped at, I think, what everyone would say is an unacceptable level. So, we've had some questions about this qualitatively in the past. Is, do physicians really know, and isn't it their office managers deal with things? And those are all fair. I would say that there's a couple things here qualitatively that are important to note. One is that physicians have a ton of patient interaction. So not only do they have their own view of who's difficult or easy to work with or who they trust on the health plan side, but they are also to a certain extent a mirror for how consumers feel. And because they're hearing that in the exam room, they're hearing that as they're talking to patients and patients' families. But I think it's also, it does seem to be at these scores, again, at a qualitative level, that this is a reflection of frustration. And these scores are down. In fact, while the hospital scores were relatively stable in aggregate, the physician scores were down across the board. That it seems the further we get into this period of significant healthcare change, it is the physicians who are the most frustrated and are expressing that frustration, at least in part, around a lack of trust overall in those that are financing the healthcare they're providing.
So finally, if we take a look at the world from the other way around, 180 degrees difference from the health plan perspective, when we asked them to rate the 7 types of provider organizations that I mentioned earlier, we see that there was a very large amount of variability. And I can tell you that the ones that clustered closer to the top in terms of provider types were small nonprofit hospital groups, small physician groups, and children's hospitals, which of course by inference tells you where the other ones lie on that spectrum. So Brandon, you had an observation about a possible interpretation of what might be going on here.
Yeah, and I think it's fair to note that my comment is there's a difference between what we think and what we know, and so this is really a what we think. I think there is a correlation here between health plans basing their ratings on the type of organization and the relative level of power that those organizations have. And power may not be a great word for it, but it's a good starting point, is that those organizations that are effectively price takers, if you will, the small physician group, some of these other entities who may not have scale, and therefore maybe not be as aggressive from a negotiation standpoint, for example, seem to be those that are best trusted by those in the health plan world who are building and running networks. Whereas those organizations that are larger and more sophisticated from a negotiation standpoint, and also perhaps have a little bit more counterweight power, larger regional IDNs, larger for-profit systems, have a lower level of trust, or are trusted at a lower level is a better way to say it. So that's, I think, a dynamic we're going to see play out here a little bit. I also think that it may be reflective of what we're seeing on the consumer side, right? That consumers, we hear this a lot in research, feel powerless in the healthcare system, and that those low trust ratings may be correlated to their feelings of powerlessness. So there's an interesting kind of two sides to this coin here.
Well, in a piece of data that we don't actually have on a slide, but it may be worth just noting in passing here, is that this same research found that twice as many of the health plan execs reported that it's gotten harder, not easier, to negotiate existing contracts between themselves and provider organizations in general. And when we asked them why that is, they cited multiple reasons for that. The common denominator seemed to be there's a higher level of resistance coming back across that negotiating table, which does seem to indicate maybe some shift in market power as provider groups get together and scale up and become larger and therefore have more negotiating power. So here we array them on the same page, just so as a recap you can see how the viewpoints differ. And basically, if we were having to look at a scorecard or a report card that came home from our high school kid, we would not feel very good about the grades that were given here. It seems like all of them are falling below that 75% mark, which would at least say we agree, if not strongly agree, that whoever I'm rating demonstrates qualities that mean I can rely on the other party, I can actually believe what they tell me, and I can know that they're going to follow through and do what they say. And it seems like as these stakeholders look at each other, what we're seeing here are bad grades. And really what that translates to, of course, is a low level of trust that exists among the parties.
Yeah, and I think you can see this really when you lay the scoring even side by side so much more dramatically, is that we all who work in healthcare will often hear they're all the same, right? And they're all the same could be applied to any one sector. Oh, all the hospitals are the same. Oh, all the health plans are the same. It's very clear from these scores that that is not how the business partners view one another, right? I mean, look at the health systems level of trust in health plans. There's a 23-point delta between the best rated health plan and the worst rated health plan. And the worst rated health plan is at a 40, right? I mean, we're not talking about subtle differences in levels of trust. We're talking about massive differences. And the same with the health plans looking out at these different provider organizations, right? We're talking about a 16.5-point delta between the best and worst rated partner organizations. So, I think it's very clear that there are areas of significant emphasis that where trust needs to improve, and that we can't just look at this and say, well, throw up our hands and say, well, they're all the same, or this problem is so ubiquitous everywhere. It isn't. There are clearly some partners that are preferred over others. There are clearly some where their trust is significantly higher than others.
Okay, audience, before we move on to the next set of findings, we have a poll question for you all to participate in. As we launch that, please answer the poll on your screen.
Yeah, and this is Brandon. I would just note one thing here is that we picked out so much talk about consolidation. We picked out this one topic in particular, particularly given Aetna's big move up. We're really curious sort of how the market views the potential impact of trust, whether that's positive, negative, or none. We ultimately could have tested either of the mergers or other topics, but we felt like sort of the convergence around news on consolidation, as well as this dramatic positive improvement from Aetna year over year, made it kind of an interesting question for us all to consider.
Okay, it looks like the poll results are in, and 78% of our audience believes that the merger with Humana will have a negative impact on Aetna's trust score. 9% said positive, and 14% said neutral or no impact.
Well, thank you, everybody, for going ahead and casting a vote. That kind of is a rather clear result, I would say. Let's take a look at the next part of our presentation here. One of the things I like to do in surveying is ask people for real commentary, not just have them mark a box or choose on a scale. And so we wanted to dig just a little bit deeper to try to understand why health system executives provided the ratings that they did when they were looking at the different health insurance brands. And you can see here a display of at least a few selected comments that seem to be symptomatic of the larger themes that we heard as we sifted through people's commentary. And that last point down at the bottom is one that caught my eye. It says, well, rates are still important, and we have to be competitive in the marketplace, and we have to fight over rates. What's happening is the negotiations, in fact, are becoming more combative and challenging. So it relates to the point I made earlier about, first I cited the health plan executive saying that, and here we have the health system executive saying it from the other side of the table. Brandon, did anything here catch your attention?
I mean, I think that, all of us who have to visit Facebook to monitor our teenagers, we've recently seen this change, right, from sort of thumbs up and thumbs down into this world of emoticons that people can place up there. And I think the disappointing thing around all this is that you could sort of capture this trust gap with this big sort of frown emoticon, right? This everyone's sort of disappointed in one another and wants it to be better, but are challenged with how to do that. And so we're going to talk about some of that and hopefully end on a much more positive note as well. So.
Well, we're gradually moving in that direction. But before we get there, I wanted to reverse the field, so to speak, and share just a few comments from the health plan perspective. Consistent with the theme of our entire presentation today, Hold'em, we see the third health plan executive saying everybody seems to be holding cards close to their chest. And it reinforces this notion that Brandon talked about earlier, that these are parties that are being forced to play together in the same sandbox, and it's not always going so well. We know that some organizations are doing a better job of cooperating and collaborating across the aisle, if you will, with each other, and others, as reflected in the results we've seen today, are having a much harder time and just do not have the level of trust in that relationship to allow them to move forward into some of the initiatives that both parties, frankly, are interested in: the pay for quality, the accountable care, and population health movement. And so you see some of the commentary here to help explain the perspective, in this case, of health plan executives.
Yeah, I mean it's a fascinating dynamic that we're seeing right now, right? I think if you talk to people kind of privately and anecdotally, everyone says the same thing: is you cannot contract your way out of mistrust, right? There is no contract detailed enough, complex enough, with enough variables and enough contingencies to cover a party that you fundamentally mistrust, and that we're all trying to do that when fundamentally what we need to really work on, it seems, are the root causes of these trust issues.
Well, then it plays right into the transition that supposedly is underway. Brandon?
Yeah, so let's talk a little bit about that, right? We all read all the time about the transition from volume to value, and I think that widely held the view is that the changes at CMS and those that are being done now in the commercial payment world, but also will trickle down from CMS. What does that really pace look like? We've asked this question a number of different ways in the past to really get at what do you think your revenues will be from value, always forward-looking, and we've really tried to pull this back to current state. And it's clear that this transition to value is slow and perhaps slower than everyone wants it to be. And we will we'll share some observations, again, qualitative observations on what we think the findings from this research mean and how it's affecting this transition from volume to value.
So what does the survey say? Well, we will share those results with you in just a moment, but we wanted to indicate that this is not only coming from our survey results. We're seeing it out in the marketplace and in the trade press, as reflected here by a comment that appeared recently in Modern Healthcare. Only 13 systems out of 80 said they derived 10% or more of their net patient revenue last year from risk-based contracts. In a similar statement, I think our sentiment came up from another source, in this case, Advisory Board, even more recently. Here we have a large percentage of the people in this particular context saying, yes, our revenue is still coming in from the conventional fee-for-service. So what did we find? We found that it hasn't changed very much year over year in the view of health system executives. They're saying, in the aggregate, only about 13% of their total expected commercial revenues this year, 2016, will be coming to them through value-based payment arrangements. Interestingly, and somewhat, in my mind, paradoxically, the health plan executives have a different view. When we asked them a similar question during the course of this year, 2016, what percent of total claims you pay for commercially insured patients will be based on volume versus value, they reported a figure that was essentially almost 3 times higher. 44% of their payments going out, they said in our survey, are going to be based on value, not volume. So it leads us to a statement here on this slide that these two players have very different viewpoints on what's going on in terms of percentage of dollars that are flowing under value-based contracting.
Yeah, and so let's talk about a couple reasons for this. I think one is I think how this question gets answered varies dramatically on how it's asked and where the emphasis is, right? So if you note on the health system side, we ask what percentage of your total commercial revenues. And so this is very consistent with what's been reported more recently in trade press and others. This transition to value-based payment is much slower, that there's a lot of pilots, there's a lot of initiatives, there's a lot of individual contracts, but it's perhaps less pervasive. If you note on the bottom, the health plan question was what percentage of your total claims you pay for commercially based. So one explanation is a percent of claims could be explained in that you might have a lot of physician claims, which are a much higher volume, right, than hospital claims, that could be driven by this value-based payment. But I think there's something more at play here, and I think there's a very vernacular-based problem, right? I think you picture sort of health system executives and health plan executives are like two countries at the UN who aren't wearing their headsets, right? They're just not speaking the same language. They don't refer to things the same way. I think we have health plan executives here who would refer to a contract that has P for P or some fairly limited performance-based payment as a value-based claim or a value-based contract, whereas health system executives really look at and say, what percentage of my revenue, right? It's still meaningful, but significantly less meaningful than most of us thought we would be at this point.
And I thought we'd ask the audience what they thought, Brandon, and so actually we've got another polling question coming up. We'll toss it back to the moderator.
Yes, audience members, if you would participate in our second poll, which is what do you think explains this gap, as we get that up on your screen. First option, underestimating the actual level of value-based payments, or overestimating the actual value of value-based payments. The definition of value-based payment is varied, Insurance companies include contracts with limited value-based payment levels or other, and you can specify using your chat function on the screen. We'll wait as those answers roll in. Okay, it looks like our results are in, and the overwhelming winner is that the definition of value-based payments varies, with 66% of the vote. Overestimating the value and insurance companies include contracts with limited value-based payment levels were tied at 14%. Underestimating got 5%, and other was 2%. Thank you all for participating.
I shouldn't be, but I'm always surprised when people agree with me. That I think we have this this just fundamental vernacular problem that exists in the industry, and I think it's been a challenge right from the first time we started talking about pop health and value-based care and all these terms, is that they become so laden with multiple definitions that it's hard to even understand whether people are talking about the same thing when they're using the same words.
So if we try to peel it back another level here and try to get behind this and say, what are the factors that are restraining the transition to a value-based payment arrangement? When we looked at everybody's scores and comments, it really was these four themes. So let's take a look at the data that actually supports this, and then I think Brandon will have some commentary to share on it as well. What we're showing you here on this next slide is the percentage of respondents who said that this particular factor was very important in terms of either driving or restraining the transition to more of a value-based payment arrangement. And we tested 8 or 10 attributes on either side of the line there, so to speak, and these were the top 5 that emerged in the view of health system executives. So they're certainly saying that some of the stuff that's being pushed on them from either health plans or the government is a strong factor in moving them towards more reliance on value. They're getting some direction from leadership all the way to the board level to move that way. Even the triple aim showed up here as one of the top 5 things. But I'd point out that trust shows up on both sides of the equation. It's the third most important factor in moving health system executives towards greater reliance on value-based payments. And it also shows on the other side of the ledger as an important factor, almost the same, 48% saying a decreased level of trust is what's holding them back, along with the other items that you note here. Again, there's some resistance that's going on inside these organizations. If you look at the second item at 62%, and that flows down obviously to and includes doctors and the physicians that might be charged with actually making this happen if you move to a bundled payment arrangement, for example. We also see that they're being held back by lack of technologies and processes, which strangely shows up on the same slide, on the next slide, where we asked the health plan executives the same question. Out of the 8 or 10 possible choices, what are the things that are moving you towards greater value-based, and what are the things holding you back? And technologies and processes are an impediment to making that move go more quickly and presumably more smoothly. We also see trust appearing on both sides of the equation, both as a driving force and something that's holding people back from striking these relationships and really doing what needs to be done.
Yeah, and if I could, just really quickly, can we pop back 2 slides really quick? I just want to make a, forgive me, I was a little late on the gun there. If we look at the health systems rating here, I think there's an important thing to point out. Note on this slide that what you really have, other than trust, is a fairly high level of acknowledgement that the driving forces are being forced to, they have to, as opposed to want to, right? And there's some meaning or reluctance, lack of technology, which we're going to talk a little bit about later. But I would say that this is really sort of a negative impetus, right? Being forced to more than positive. If you flip to the next slide and look at the health system, the health plan side, it's all want tos, right? 69% say the driving force is gaining a competitive advantage, which doesn't even show up on the health system side. They want to do this to increase trust. They want to do this to gain physician support. These are want tos. These are positive impetus, not negative impetus. So part of that vernacular problem, I think, also is that health systems in particular may be looking at the value-based world as a bundle of threats, whereas health plan executives may be looking at value-based as a bundle of opportunities, which is a very different. To Dan's point, though, this is really the most important piece of this. look at the continuity here, right? On what's the restraining force is trust, what's the driving force is trust, right? So people want to do it because they want to do business with a trusted party, or they don't want to do it because they don't want to do business with a party they don't trust. And if anyone on this call is wondering, does trust really matter in a B2B environment? If we don't fix the trust problem in the B2B side of healthcare, the transition to value will continue to be slower than everyone wants, the industry, the government, and consumers as well.
I think that's well put. And it, of course, brings us to bringing trust into the center of our attention as we think about moving forward. And it's a way of saying that we didn't just make this stuff up about trust. It really is supported by the data that we've received this year and in the previous years as well. So it kind of brings us to our final section of our webinar today, which has to do with closing that trust gap. Brandon, do you have some observations you want to share as we move into this material?
Yes, I think that we're gonna cover 5 things. You know, there could be 100 we could put on this list, but we're going to focus on 5 things, some of which have some really good examples that we can point to as well. Dan, I want you to cover number 1 on kind of knowing where we stand, but we're going to touch on some real quick examples on all these and then open up for questions to the group.
Number 1, obviously, is understanding where you stand now. What is the level of trust between the different stakeholders that are within your brand? And for example, if you're a health system operating in multiple cities, maybe even in multiple states, how do your internal stakeholders feel about the brand itself, the brand that you represent as a health system? And are there gaps in the way that your stakeholders view these issues of trust? Do the employees have a lower level of trust in the brand than, for example, consumers in the broader marketplace? Where do physicians fall in that mix? And we would recommend that a piece of survey work be done to actually establish where a brand stands today and to understand where there are strengths and where there are weaknesses. And if you're going to measure trust as we have with the Trust Index, you could ask yourself, well, what do we do about it? And what these 4 circles represent to me are the domains of action, the areas where you need to focus attention. And what a trust gap analysis could indicate to a health provider is which of these areas you need to focus on most heavily and with which stakeholders. So I would recommend know where you stand as step 1 in trying to close that trust gap.
Yeah, and I think to Dan's point, right, that can be done at a market level, that could be done at a state level, that could be done with a particular segment of your B2B set of relationships, and it is certainly not sector specific, meaning health systems could be doing this, health plans could be doing this, physicians could be doing this. I think there's just such an imperative. We've aggregated data, we've looked at this at national levels, we've looked at it by industry segments. There's nothing that really matches up to having real life data from your market for your organization. So I think the others, we'll mention an example here, and there are a lot of examples that we could offer, but we really think there's an opportunity for both health systems and health plans to think very differently about their health plan and provider relationships. Right? So an example that we'd offer here is the Vanderbilt Health Affiliated Network, done in close relationship with and collaboration with multiple health plans, but starting with Aetna. There are some other really great Aetna examples from around the country that people have read about in the trades of joint venture health plan with Inova, with Banner, one just announced with THR. I think some of that may very well be part of the explanation of this great movement up on the trust side for Aetna. But Van, if you haven't read about it in the trades, it's worth going to their website and checking out some of the data that's online. It's a great example of a network built differently, built in partnership with health plans, but in a particularly close initial relationship with one health plan, and really has both parties thinking differently about the nature of that business relationship and what it can mean for the future for the populations that they're serving. The other we'd mention is, some of this stuff can seem really daunting, right? And I think that trying to fix a trust gap in a massive and complex and highly regulated industry where data is not always transparent and available, which we'll talk about in a second. One of the pieces of advice, the strategies we'd offer for closing this trust gap is just starting small and then building and scaling up. And Tenet is a great example that we would offer here where in 2013, Tenet had 313,000 lives in 6 Medicare ACO markets. With a number of health plans that you see, including CMS, but a number of private health plans that you see listed as well. By 2016, so 3 years later, coming up on triple the number of lives, 826,000 lives, so almost 1 million lives, and in 15 markets, right? So 2.5 times the number of markets. So one might look at that and say, gosh, 3 years, that's a lot of scale to be built, and it is, but it's a great example of not just building pilots and testing things with certain plans, but then taking the learnings and really building up these collaborative relationships that have meaningful value-based payment attached to them. And again, you notice some of these trends around what names are popping up, who they're doing business with, the trust ratings for an Aetna, and that's part of that big jump in scoring. But we think everybody, it seems, has some of this, but whether there's a lot of it and whether it's being scaled over time is part of what's going to help to close that trust gap for both sides of the equation. And I think this data piece can't be ignored, and we're going to offer an example here from a really interesting company, Arcadia Healthcare Solutions, in partnership with a group called Community Health Plan of Washington. But the finding here, the strategy, if you will, is finding a trusted partner to deliver relevant, trustworthy data. I think if we all who work in this industry hear this over and over again, is that the health plan doesn't like the provider's data because it's incomplete. The provider doesn't like the health plan's data because either they don't trust it or they're not sure whether it really reflects current or whether it's being shared in a particular way to make a particular point. But there are organizations, and Arcadia is a great example of this, where taking EHR and claims data in real time that really allows an innovative pay-for-performance program, and building that on a technology platform that both sides can trust. They can trust the data that comes out of it, that it's not retrospective, that it's not aged, that it's not been in some way sort of watered down, if you will, but is really in real time and allows for decisions and adjustments. Again, if you haven't read about Arcadia or about this particular solution, I think there's a really interesting strategy to be pursued that gets us out of this problem. If we don't trust each other, we can't trust one another's data. Let's get a data source in the middle then that we both can trust and can look at that. And then lastly, we've talked about sort of finding out where you are, and then some very specific strategies for addressing this. But there's also just the need for better communication, information sharing between the parties, right? We talk a lot about health systems and health plans, but the physicians who are seeing these patients and seeing a high volume of patients in their offices, the different sectors of those types of physicians, the need to really close that communication gap. And that information gap that is a part of the trust gap, right? That where information is available, not just data, but information, where it's being communicated effectively. And Dan talked about sort of benchmarking it, finding out where you stand early on. If the first step in a 12-step program is acknowledging you have a problem, right, meaning identifying what the nature of it is, then all of the other steps are about doing something about it. And we've just shared some very specific business ways of doing that, but there are also just communication ways of doing that. And obviously there's a certain amount of that is self-serving for us, but whoever it's done with, and whether it's done internally, there's an obvious communication gap that exists in our industry at the B2B level that is then being exacerbated when it gets out to the consumer level.
Okay, everyone in the audience, we have one last poll for you on this webinar, which is, what do you think your organization does well? Please answer on the screen as you did with the other polls. You can choose between these options. You can select all of them if you want, and we will wait for those responses to roll in. Great. All right, everyone. Thank you so much for participating. Looks like competency came out on top with 58%. Compassion comes next with 48%. Then communication, consistency, and 10% chose none of the above.
That 10% is a sad number. It may be true, and we all want to acknowledge that on some level. But yeah, I think the good news there is compassion popped out pretty high. It has to, right? We can't be in this business and not be motivated by compassion and demonstrate compassion to those that we're serving. But I just think it's also got to be across the board with these different areas, right? Competency without compassion is cold. Same with consistency. But if we're doing all those things well and not communicating, and no one knows we're doing it, or that message may not be getting to them as well. So we got to get all that 10% and none of the above up into one of the other categories, and we got to get all the categories up as an industry.
Brandon, that brings us pretty close to the end of the hour that we promised to be on the call with people. We might have time for a question or two if we can keep our answers short. So I guess we'll see what might have rolled in on the question front.
Yes, thank you, Brandon and Dan, for that fantastic presentation. As you mentioned, we'll begin today's Q&A session. We have a little bit of time left, so we will take some questions. If you have any in the audience, please submit them by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We'll try and get to as many as we can in this short period of time that we have. All right, to start, the first question is, can you explain the large range in the Composite Trust Index score for health plans' level of trust in health systems?
Well, I think the short answer is that they see these different types of provider organizations very differently. And it's based, we assume, on their direct experience in contracting with these different kinds of provider organizations. So as we saw in the conversation earlier, the larger groups seem to have more power and therefore are getting a lower trust score in the eyes of the plan executives.
Okay, great. The next question would be, with 10 years of historical data, how do the composite scores compare to previous years, and are we closing the gap or is it expanding?
Brandon, you want to try that one?
Yeah, so I think the hospital scores were very modestly improved, within the margin of error improved. The physician scores were across the board down, but not dramatically. So it's sort of interesting that over 10 years we've had various health plans who have scored as the top health plan, always sort of among the same set of three. Aetna, Cigna, and Individual Blues have always been kind of among those top three. We've always had one health plan that has managed to pull up the rear, but I think that the sectors on the health plan side were sort of interesting. Dan just addressed that. This was the first year we've tested it. We'll be very interested to see how that trend changes in future years of surveys.
Brandon, it looks like some people are again asking about the individual score question. Can they get their individual scores? Do you want to repeat that as we close up? What your feeling or statement is on that?
Yeah, I think as I mentioned when we were revealing the overall scores, because we cannot test the overall scores of provider organizations by name, only by sector. We are not releasing to the media, at least, the scores of individual health plans. We will make those available to any health plan that wants to know where they fall on the spectrum, provided that it is not released to media and done privately. And we will do the same with provider organizations. We're happy to make the data available. We wanted to go out of our way to make clear that this was about identifying the trust gap and not about singling out or embarrassing any one company.
That makes
and
sense.
finally,
Thanks for clarifying. Oh, go ahead.
I was going to say, do you want to tell us again when the slides will be available for people that want the entire slide deck? It sounds like it'd be about a week from today. Is that everybody's understanding?
Yes, definitely. Everyone on the audience who's wondering, we will send you a copy of the presentation to the email that you used to register in about a week. So you can expect that in your inbox in about a week.
And I'd also just mention to the group that I'm sorry, Dan, I was just going to note too, you'll see a URL on your screen right now. The findings from the survey that we just went through are also all available at that URL, and we will also work to get the slides posted up there as well. So you can wait for it to come across to you, or you can drag this URL, and we'll get the content posted there as well.
Perfect. That sounds great. It looks like that's all the time that we have for today, so I want to thank Brandon and Dan for your excellent presentation, and to everyone in our audience for participating today. Enjoy the rest of your afternoon, and we look forward to having you join us for future webinars.